Hi, my name is Thomas, and on behalf of all the co-authors I want to present you our paper called Aetiology, Secondary Prevention and Outcomes of Ischemic Stroke Despite Oral Anticoagulation Therapy in Patients with Atrial Fibrillation. So we know that there is a considerable residual stroke risk in patients with atrial fibrillation, ranging from 1 to 2% in primary and secondary stroke prevention. This means that 1 in 6 patients with ischemic stroke is on oral anticoagulation at the time point of stroke. However, the mechanisms underlying ischemic stroke despite oral anticoagulation are poorly understood. So we sought to describe the assumed causes of stroke and investigate the secondary prevention strategies used with outcomes. We pooled individual patient data from 11 experienced stroke centers, and it included patients with known atrial fibrillation before stroke onset, imaging-proven ischemic stroke, and oral anticoagulation therapy at stroke onset. We excluded patients with missing data on oral anticoagulation treatment and mechanical heart valves. The reporting period was from 2012 to 2020. We classified the etiology of ischemic stroke as competing etiology if there was significant evidence for small vessel disease or large artery disease or another cause. And we classified it as insufficient anticoagulation if there was self-reported non-adherence, incorrect low dose, or suspected based on anticoagulation levels or INR. We classified it as AF-related despite anticoagulation if neither of the above was present. The secondary prevention, we looked at which anticoagulation was used and whether antiplatelets were used in addition, and the primary endpoint was the composite of recurrent ischemic stroke, intracranial hemorrhage, and all-cause death at 3 months. We had roughly 3,000 patients, median age 81, roughly half of them female, moderate stroke severity at NIHSS 6, and a bit more than half of them were on direct oral anticoagulation, and a bit less were on vitamin K antagonists. Overall, a quarter, seen in blue, had a competing stroke mechanism, and a third had insufficient anticoagulation therapy. But most of them had AF-related cardioembolism despite sufficient anticoagulation. DOAC patients had a bit more competing etiology and a bit less insufficient anticoagulation. When we look into the competing etiology in detail, most frequent was large artery disease, followed by small vessel disease, but also other specific causes were found without significant differences between the groups. Here you can see what physicians chose to do with the oral anticoagulation before stroke and after stroke, and you can see that there was a heterogeneous picture. If we look at the association of discharge treatment with the composite outcome, we could find that the use of direct oral anticoagulation was associated with a lower risk of the composite outcome. However, the addition of antiplatelets was not associated with lower risk. In fact, the risk was higher. However, this has to be taken with a grain of salt because of indication bias. Regarding switching from 2A to 10A inhibitors, or switching the medication overall, or switching once to twice daily, or vice versa, was not significantly associated with a lower or higher risk of the composite outcome. Strengths include, this is a large sample, and detailed characterization of ischemic stroke etiology from experienced stroke centers. However, observational data retrospectively collected and non-randomized, and we had too few patients to look into other preventive strategies such as left atrial appendage occlusion. I want to thank all the collaborators and you for your interest.